Good afternoon. Thank you for being here. We get started with our next breakout session and are very thankful to have Skylar as well as Socorro here to talk about their experiences. Skylar is from Mayo Clinic and is a patient navigator that and he's been in this space for 3 years working with the Mayo Clinic Comprehensive Cancer Center. And then Socorro here works with the SAGE program. And the hope really is to get an insight into the lives or a day of a patient navigator with a goal to understand what gaps they're fulfilling and what more can be done in this space. So we look forward to that. Starting with Skylar here.
All right, I've got a little PowerPoint I'm going to give here. So my name is Skylar Martin. I'm a patient navigator with Mayo Clinic Comprehensive Cancer Center. And I'm going to talk a little bit about the patient navigation program, and more specifically, the population-specific navigation program that Mayo does. First, I want to start off with just kind of showing a little bit, telling you a little bit about myself. So I am an enrolled member of the Stockbridge-Muncie Band of Mohicans. My reservation is about 45 miles west of Green Bay. Yes, that legally I have to be a Packers fan, so don't hold that against me. I'm also a descendant of the Oneida Nation and a graduate from College of Menominee Nation where I studied public administration. I started at Mayo Clinic as a desk operations specialist, which was important because it really gave me the foundation I needed to understand the complex system that is Mayo Clinic. Once I was able to navigate that, then that, of course, transferred into my current position, which is helping the patients to navigate the system. So this is our navigation team. We have our supervisor up on top who actually supervises all 3 sites. So we have sites in Jacksonville, Florida, Phoenix, Arizona, as well as Rochester. Now you'll see I have a counterpart who works with the American Indian and Alaska Native population down in Arizona, as well as we have a Hispanic and Latino population navigator down in Arizona. In Jacksonville, we have the African descendant navigator, and again, another Hispanic Latino navigator. And then up in Rochester, we also have besides myself, we also have the Hispanic Latino navigator there as well. And then down on the bottom row, you see our general navigators. So the general navigators will assist the patients who don't fall within one of these other populations. How we chose those populations and the sites for those populations was all based on the demographic makeup for those sites, or in other words, our catchment areas. And so one very important distinction here is that our patient navigators help with non-clinical barriers. Okay, so we differ from nurse navigators. So I want to make sure that there's that distinction here. And so some of the things that we can assist with are like employment concerns, financial assistance, which is really huge. A lot of our patients do come to us asking for that financial assistance, which we'll use a lot of third-party organizations. And then we can also get into insurance concerns. One of the most popular across the board for all of the navigators are lodging options. For my population, the closest Native American reservation is the Prairie Island Indian Community, otherwise or the Mdewakanton Sioux, who are just south of the cities here. Otherwise, the rest of the population, the rest of my population is coming from reservations that are spread out. It isn't uncommon for me to hear my patients having to drive 10 plus hours to come for appointments. And now, they get to Rochester, they have their consult, everything's looking good. Then the doctor tells them, guess what, we need to keep you here for another 3 or 4 more days. You get the deer in the headlights look, how am I going to afford a hotel for that period of time? Well, thankfully, our supervisor, who's been a part of the navigation team for 18 years. She actually had developed relationships with some of the local hotels, and she really wouldn't even consider them unless they gave a very, very considerable discount, which we're very fortunate to have those partnerships, and we rely on them quite heavily. So this is Mayo Clinic's approach. We do the care team approach. So as you can see, the patient navigators are a part of that care team. What that allows us to do is we can actually communicate with other members of the care team. We can also help communicate the patient's wishes. If the patient isn't big on self-advocacy, we can definitely be that advocate for that patient. So it also allows for those other members to be able to refer patients to us, or if say the social workers know that there's a known issue with this patient, they can contact us and give us kind of the heads up and say we maybe need to focus on this particular area. So how all of this works is it really starts with the patient self-identifying at registration, which is very important. So once that patient self-identifies their race or ethnicity, then they'll actually populate a report that is in our electronic medical record. We'll run that we'll run that report. That report will actually generate a list of patients who are going to have oncology appointments for the next 2 weeks. It'll go out 2 weeks for us. We can also push it out farther if we wish. But generally speaking, looking ahead 2 weeks, it gives us a good chance to connect with those patients. Now, once we've run that report, the population-specific navigators will actually filter that report down to just our patients. So I'll know all of the Native American cancer patients who have at least self-identified and that they have oncology appointments for the next 2 weeks. So once I've identified these patients, then I can reach out and do an introductory phone call. If that phone call doesn't work, if I can't reach the patient that way, we'll try either using email, or we can also use a online patient portal, basically using the patient's portal for connecting with them. We'll meet with the patient. We'll kind of do our assessment, see where the patient's at, what are their needs, and then we can also make referrals out. So if we notice that there are some psychosocial issues going on here, we can refer them to social work. If they have spiritual needs, we can refer them to our chaplain services, which, a point of fact, for my population, Mayo Clinic Rochester actually has 2 smudging rooms. For those that aren't familiar with what smudging is, it is a practice that Native Americans do to kind of help cleanse the spirit, cleanse the air, if you will. And it's used in a lot of various healing ceremonies and even saying prayers, things like that. So the fact that Mayo recognizes the importance of that spiritual piece, and it's important to my patient base as well. They really feel welcomed once I first introduce myself as being Native American, and then next telling them that that Mayo Clinic does care about your spirituality. We do care about you as a whole person, and we can include that in with your care treatment. So if the patient does not self-identify, if the patient just chooses to say, nope, I'm not going to answer that question, then we're kind of dependent on internal referrals. And those referrals can come from just about anywhere within Mayo. And it's anybody that makes up that care team. If they see or notice something that maybe perhaps we need to be involved, they'll reach out to us and say, here's this patient, would you mind connecting with them and seeing if they're interested in your services. An interesting point of fact we've discovered is with the Hispanic Latino population tend to like to use WhatsApp for communicating. My patients, I can get through to them pretty easily. Once I make that initial phone call, I can usually get through them pretty easily using the online portal or email. And then another referral area that we can get referrals from is the community partnerships, such as the American Cancer Society's Hope Lodge. Sometimes we'll have a patient who will reach out to the Hope Lodge proactively seeking lodging. Hope Lodge can't facilitate all of those requests, so a lot of times they'll refer them back to us patient navigators and say, here, this patient is in need of some lodging assistance. Would you mind talking over the options with them? And then, of course, word of mouth. You know, anytime that we've got, especially like within the Native American communities, we've got, you know, the tight knit, close relationships. So everybody kind of knows somebody who's got cancer, you know, is going to be traveling to Mayo Clinic, and they say, hey, you know what, I ran into this patient navigator, you should connect with them. So the impacts have been very big. Doing the outreach, you know, just simply reaching out and saying, "Hey, I'm a Native American cancer patient navigator. I'm here to help you. What can I help you with?" And so many times I've heard my patients say, "Really, this is for real. Mayo is doing this." I was like, "Yeah, yeah. This is what we do. This is what I do. What do you get out of it?" Nothing. It's my job. It's what I do. It's just helping somebody else. So then we pretty much just guide the patient through, identify any of the problems that they have, and then schedule up any kind of follow up that may be needed. One of the other issues that we deal with is the medical mistrust. With my patient population, they've struggled with the Indian Health Service, which has been, you know, severely underfunded. They've had a lot of different struggles. Even the patients just trying to get a referral to Mayo is oftentimes a struggle. We're seeing a lot of those, the patients from my population, because the struggle is so real for them to get that referral out of the Indian Health Service and to Mayo. We're seeing a lot of patients presenting with late stage disease, advanced disease, which really should not be happening. And of course, there's just that just general mistrust that, you know, these guys aren't looking out for my well-being. And so by me making those initial contacts and kind of informing them that yes, Mayo does care, and yes, you are going to be taken well care of here. And then also we can also address cultural misunderstandings. So we also serve not only to educate the patients, but we can also educate our fellow employees, the providers who've never had, you know, contact with Native American culture, or somebody who's never had contact with that Hispanic culture and don't understand what it's all about. We can help kind of bridge some of those gaps. Identifying language needs, that's very huge. Not so much for my population. However, down in the Southwest region, there are tribes that still very heavily use their language, such as the Navajo. Up here, unfortunately, we've had a lot of the tribes have had that European contact early on, and kind of some have lost those languages, such as my tribe. Our language was actually lost, but you know, there's a space for everybody. And then we really do try to work towards getting that patient so that they can self-advocate. You know, they're no longer reliant on my services. They can actually feel comfortable talking to their doctors. And one of the ways that I've tried to do that is I'll ask my patient population when I first meet my patients. I'll ask them if they practice any of our cultural, you know, any of the old traditions, any of our old medicine ways. And a lot of times, you know, they'll kind of look down and say, "Well, yeah, yeah, I do." It's like, don't be ashamed of that. You know, open up, be open with that. You should be able to have that conversation with your oncologist, just like, you know, saying, "Hey, I took an aspirin this morning. Well, this morning I burned some sage and I drank my number 6 tea." You know, it just should just be natural, and everybody should be on the same page with that. And then we can also, again, providing that spiritual and emotional support. Um, and I see a lot with the Hispanic Latino navigator. She brings in the chaplain services quite a bit, and meets with her patient population. And then I have a lot of my patients that will utilize the smudging rooms or some of the other services that are there as well. So that's really about it. That's my contact information. If you want to reach out to me, if you've got more questions, feel free to shoot me any questions that you got. Or even if you know of a patient that could use my services, please send them our way.
We'll wait for Q&A after.
Mhm.
Hi, Can you hear me? My name is Socorro Felton, and I am a SAGE rep in the call center. When patient calls to get an appointment through SAGE, they may get me on the phone. But I want to tell you a little bit more about me so you can understand how I got to be what I'm doing. I am from Mexico City, and 41 years ago, I came on vacations to Minnesota. My husband was born and raised here in the Wilmar area, and we met on vacations in Cancun. I tell people that he was a very good rep, sales rep, because he convinced me to come to Minnesota. He wanted me to come to Minnesota to see what Minnesota was all about. So I came in the winter and to meet his family, and it was for Christmas. I came in '81, and I tell people that when I came, I got out of the airplane and my brain froze, and it's been frozen since then. So I came the following summer to experience the summer, and I stayed. And a year later, we got married, and when I came to Minnesota, my English was very limited. I had learned English in high school, and after that, I kept going to classes, but it was like once a week for 2 or 3 hours. And I could read and I could understand what people would talk to me very slowly. I could understand. But if someone would speak to me really fast, I could catch one here, one there. My husband did not speak Spanish. And when I came here, we could communicate again because he spoke very slow to me. He was a chemical rep, and the UPS man would come daily to our house and drop boxes. And being in the rural area 40 years ago, you never lock your door. So one time he was not home and I was home alone. The UPS man came and knocked at the door and opened the door and dropped, and he saw me and he started to the day I'm still wondering what was it that he was telling me. So that is where it's bringing me to what I'm doing. I like to educate people that cannot understand the English language, so they cannot 40 years later still wonder, what was he telling me? I have done, again, I lived in this West Central Minnesota, the Wilmar area. And when I came here, I probably was one of 50 people that spoke Spanish. Hardly any people throughout the county. Migrant people would come and leave, and they would not stay here. And then suddenly they start getting people to stay in the area, and they needed somebody that would speak Spanish. So I got hired by the school. By then, I spoke better English. I could understand more. So I have moved from one place to another, helping the Hispanic population. Through the last 40 years, I moved from working as a paraprofessional to the school and doing parent-teacher conferences to working with children's mental health and being family liaison with Hispanic populations. My caseload, because I was married to a Norwegian, my family was an intercultural family. a case, I work with family services, and my caseload got to be about 35 families within, again, English speaking families and Latin American families. And from there, I moved to SAGE, working with the clinic and teaching people in the population of the area, the Hispanic women, about breast cancer, cervical cancer. While I work at the clinic, the service went from, I believe, 5% of the Hispanic population to 17-20% of the population, the women were getting screened because I was doing the outreach. I was teaching women about breast cancer, about the importance of them getting screened in their language. They could understand. They were not, they knew why they needed to do this test. So the reason that, it's important for clinics, for providers to be able to use someone that can provide that message directly to someone that can understand them is really, is very, you probably know, is really a good what should I say, a good service for those patients. Through my experience doing SAGE and working in the community, in the Latino, with all the Latinas, I also interpret for the doctors. It was, for me, it was again very important that those women would understand, and not just that, during their treatment with the doctor, I would go in and I would explain, the doctors were talking and I would be explaining to them. I went and I trained to be an interpreter. So I did a lot of simultaneous interpreting with the doctors in the clinics. And the service that they were receiving, it was a little bit more geared to that patient. When I was doing that service, to me it was important that I would provide that service directly because I had learned how to, how to talk to the women about breast cancer, about cervical cancer. The regular interpreters in the clinic interpret every day with the doctor one-to-one, but they had not gone to training for breast cancer or cervical cancer. I decided to myself to go and to all the trainings that the nurses, that the clinic was providing to the nurses about breast cancer, about cervical cancer. I didn't get the benefits of a nurse, but I got the benefit of learning to be able to explain to my patients why they need it or whatever the doctor was saying. If the doctor was saying something that they could not understand, then I would ask them, can I ask your doctor so the doctor can, tell you better? That was very important. The patients felt comfortable. It got to the point when I work at the clinic that they would just come directly to me to, because they wanted to ask the doctor, and they didn't know. And I would sit there with the patient and I would ask them, you tell me exactly what you're feeling, what you want to ask, when the patient was also diagnosed with breast cancer, I would tell them, go home and write everything that you are feeling, everything that you need to know from your doctor. Every question, everything that you want to know, what is going to happen, what are your possibilities, everything. And then you can either come to me and we will talk about it and we will resume it in questions for your doctor. That helped those patients a lot. Part of it is because when you are from a different country that you are not, in your country, they are not teaching you about the importance of screening, of prevention. You don't know what to ask. You don't know um, what, you don't even know what decisions you can do for, So, to my experience working directly with patients, is very important that they can express themselves to somebody that speaks their own language. And, and we talk a lot about cultural competency, and somebody earlier mentioned, I don't think anybody can be competent, even in your own culture. As I said before, I was married to, my family was intercultural family. My husband was diagnosed with brain cancer. And at that time, we were going through a lot of difficult times. And it got to the point that at one time, someone approached me and they told me, I think you're misunderstanding. I think it is a cultural misunderstanding. And at that point, I told him, you know, my husband and I, we have our unit. We have our own culture. Yes, he can be, Norwegian, a white person with a different culture than I am. I am Hispanic and I have my culture, but we are blended culture. So remember that when you're working with patients, you are working with a patient that may be a Hispanic, it may be from Mexico, it may be from Guatemala, it may be from, but they are also different. So when you're working with Latinos, Latinas, we're not all the same. So you have to kind of remember, that, maybe we're speaking Spanish, but believe it or not, when I am talking to a lot of the Latinas from Guatemala, I have to ask them myself, what do you mean when you're saying that? Because I don't understand what they're saying. So even if you're working with an interpreter, uh, don't think that interpretation, that communication is going through, because the interpreter might say a word that that person may not understand. So that's another issue with, when we're working with people with different uh, languages, from different cultures, from different countries, and that, has to be kind of acknowledged, because a lot of the interpreters are really good. I was one of them. But again, if they are not catching that the patient is not understanding, they are not going to try to help. They are not going to try to ask the patient, did you understand what I mean? Or if if they are not asking the patient, can you tell me a little bit more about that word? I did not understand it. So you can translate it to the doctor or the nurse. Um, so those are some of the things that they are very, very important for, when we're working with patients that are different language, different culture, different um, customs that even again, I have to remember that all the time. One of the things that I do want to kind of mention, we just had the Scopes program with the SAGE, and my supervisor is right here, and she reminded me earlier there was a question about the colonoscopies and why, a lot of patients are not following up. I spend a lot of time going through with each single person, explaining to them the prep so it could be successful. So when you follow up with the patient, and you kind of cater to them, they are going to answer. They are going to, follow with what you're teaching them. So that's all. That's my whole speech that I had. I just wanted to, talk about my experience and about why it's so important for someone with a different language to be able to feel comfortable and be able to communicate with someone that is understanding and that is able to provide the correct information for them. Thank you.
Yeah. Well, thank you both. Just some of the questions that I thought we would get started with, and then the audience can ask theirs. One of the things that I was curious about, you said you connect to a lot of community resources. What happens if a patient is, let's say, positive in their screening, um, and they're not able to seek care immediately in the institution that, especially you with the SAGE program? Are there community resources that you connect them to for eventual care?
For it, I work with the breast and cervical cancer. So we normally, if a patient is diagnosed, we are able to help them connect with services, either breast or cervical. We also have some information in our call center in case that they are calling for something different. Depending on the situation, whatever they are calling, we have information that we can either give to those patients so they can follow up or transfer their calls.
Thank you. And in terms of the continuum of care from, screening all the way to detection and then diagnosis, medication management, and palliative care, what range do you work with the most in terms of patients? Is it mostly screening?
I with us with the
Yes.
SAGE program, yes. So maybe
And
the clinic.
for us, it would be mostly it would be mostly that treatment area. So a lot of my patients are coming in for that second opinion, or they've been told by their current providers that there's nothing more they can do, and then they'll reluctantly refer out to Mayo.
And you mentioned the blended culture. 300% growth rate is what they're seeing in blended cultures now every year, the largest growing demographics. So, how do you interpret the cultural component versus just the language component? Are there specific cultural differences that you see, even though they might all be Spanish speaking, that you care to comment on?
You know, I probably, and I don't know if anybody here has a blended family, that two culture home. What I can say is that when you marry somebody that is different culture than yours, you're going to bring both cultures together. My husband brought some of the whatever things that he grew up with, and I did too. And a lot of times we talk about it. We figured out that, oh, yeah, I learned that from my parents too. And, we had a lot of similar things that we both grew up with. I think sometimes that's why you get together with somebody from a different culture, because you do kind of have similar, can't pronounce that word, similarities, in the way you grew up. However, again, because this is a blended out of two cultures, you are creating your own culture in your family. Is you're not following up the rules that you grew up with in your own family, and at the same time he's not following the same rules, because you are becoming together and you're making a decision that is going to be good for you and your kids, that may be different than the one that you made with your parents. So however, what I want to say, excuse me, with me, it was a little different because I am the only one in here. My family is still in Mexico. So my husband and I had to make decisions between what it was good within our family. But a lot of the Hispanic families, a lot of the minority families, if they are have their families around, they're going to bring that. Remember, they're going to bring that within that decisions. They are going to talk about it, especially if they have their parents, their grandparents. I am seeing a little difference now within younger generation of Hispanic families. Generations, they are not so much relying on their elders as they used to. In the contrary, with the Hispanic population, you're going to see a lot of the parents are going to rely on the younger generation because they are the ones that speak the language. So they are the ones that they are going to be asking them to translate for them, or they are going to be asking them what they should be doing. So it is important for them to have those grandchildren or or kids to be part of them, whether it is their treatment or whatever they need to get done. And if they can, I tell them when they call, when I'm talking to them, if you can take someone with you that speaks Spanish, whether it is your son, your daughter, or someone in your family, to those appointments with your doctors, that will be good because they can understand. Don't rely just with the interpreters telling them, because a lot of times when someone can speak the language, they can help you make that decision.
And Skylar, how about you? Each tribe is a sovereign nation, they say, and probably have their own culture.
Hmm.
So, how do you work around the cultural barrier or cultural differences, I would say, between each tribes, between
There
each of the
is
tribes?
certainly some differences there culturally, but for the most part, we're the same. We have a lot of the same beliefs, just in a different manner. And one of I actually watched a documentary the other day on Netflix called Gather, and it
Mhm.
really focused on tribes that are trying to regain some of their culture, some of that culture that was lost. And so, in there, the one gentleman says that he runs into a lot of younger Native Americans who don't know the ceremonies. You know, they don't know the language, they don't know the dances, they don't know the drums, and they're embarrassed by that. And he has to tell them, "Don't be embarrassed.
Mhm.
This is the federal government. This is what they wanted. They wanted to eliminate our culture, and they succeeded admirably. Now we have to try to fight to get it back." And so that's where I want, when I meet with my patients, I want them to know, feel free to discuss your culture. Feel free to express yourself to these, to these non-native people, so that they'll learn and they can be accepting.
I mean, you mentioned both of you the shared decision making, which is a big component of a lot of cultures. Um, do the physicians respond pretty well to that? Because I know there's a lot of authorized individuals that can receive your medical records or can talk to you about that. Have you had to advocate for patients who want to bring all their family members in to the decision making? Um, do you want to comment on that, either one of you?
I think we see a lot with the minorities, especially. You see a lot of the multi-generational homes, and so now it's maybe grandma and grandpa at home taking care of the kids while mom and dad are at work. Well, now if grandma and grandpa got to come for treatments to Rochester, that kind of leaves the family stuck. So a lot of times they do have to bring the extra members with, and for the most part, I think everyone within our system has been pretty welcoming for that.
How about you? Do you want
It's been a long time since I work in the within the clinic
to?
system.
Okay.
Um, but I think during the COVID time, it was harder for what I heard in the phone, that especially the Hispanic population, they always tend to bring someone with them to the appointments, whether it is one or two other people. During COVID time,
Right.
they did not want to come to the clinic because they had to come alone, and it was intimidated. They felt intimidated to go to a doctor's visit alone. So I think most clinics nowadays, they are still, they want, they have open doors now, so people are starting to come a little bit, more with two people. But that's what I heard during the COVID.
Right.
Most of my patients, the patients I would call, they would say, no, I don't want to schedule an appointment because I don't want to go alone to the clinic. So that was one of the things that, um, as far as sharing records and so on, it's been a long time since I worked in the clinic, so I cannot really comment about that. So,
Well, I'll have just one last question, then I'll open it up. As far as metrics go, are there target metrics that you have in terms of screening or in terms of treatment and diagnosis that you are aiming for? And do you keep track of those records to see if you've been in the system for a long time, it's hard, but I mean, are there target goals? And then do you see a difference with the patient navigator versus not? Um, just curious.
With us, with it being a fairly new program for the population-specific navigators, I wouldn't say that I mean, we're obviously, measuring everything, gathering data, but I don't believe that we're really, there's targets. They're not saying you have to meet, this many patients, or you have to have, we're not to that point yet. As we are developing and really just kind of growing at this point. But we track everything that we can.
we we at Sage, we pretty much have our guidelines, and we serve, as long as people follow within the guidelines, we help them, we serve them. So
And so you've seen an increase in survival rates, 5-year survival rates, or something to that effect.
I, I will say, I don't. We must have that information. I don't know. Do you have any? We do have that information, but since it's not my department, I apologize.
No, that's
I
okay.
don't have that information. Yeah, we do keep track of that, but it's just, yeah.
All right, I open it up to all of you. Any questions?
Thank you both for sharing your stories and what you do. I have a question about navigation in terms of earlier detection. You mentioned you see a lot of people that have late stage disease, basically they didn't get into the system early enough. So I'm curious how patient navigation currently is educating people and getting people into the system to get screened when they need it, and or is there opportunity to further grow in that domain? How do we increase the awareness for screening in a culturally, I'm not so sure to say competent, but efficient way?
That's really held by another department within Mayo Clinic that really does the outreach. At one point, there were some thought that the patient navigation should be the ones going out into the communities and making these suggestions, doing the education. But really, we're patient facing. So any of our time that isn't at the clinic, such as today, I'm not meeting with my patients. So that, we could have the potential for patients kind of slipping through those cracks. But thankfully, Mayo, has recognized that need, and it has created the departments that to reach out to those very specific communities.
Thank you.
With Sage, we normally do a lot of promotion of the Sage program. We also do partner with mammography units to do mammograms in the communities. But I will say that probably the most effective way for minorities to learn about our program is word to mouth, because they normally, when they are calling and we ask, how did you hear about our program? They normally are referred by family or a friend that has used our program and that they know what we're doing. Um, that is what I hear a lot in the when they're calling our call center for those minorities. Yes, me.
I stole the microphone from her because I was right next to her. It worked out well. Thank you both so much for the work you do. I work for ACS CAN, and we're talking a lot about expanding patient navigation, making a billable service. Like, how can we use our advocacy work to expand this? But I ask this as someone who's also a former case manager. As we think to continue to expand the work, how do we ensure that the staff who are on those front lines, like really serving these populations, holding like a lot of really hard and big things, spreading out their capacity? I have no idea what your caseloads are, but like, how do we ensure that we can grow patient navigation without kind of harming the people who are really going to be doing the work and serving the patients? So I don't know, like, what's your experience? How do you take care of yourself to ensure that you are able to continue to do the work and show up the next day and for months and years to come? But how can we like keep that in mind as we work to expand this important service?
I think one thing that would be nice is if we could almost standardize to some degree what's being done. I actually took part in a research study through the University of Oklahoma that looked at American Indian, Alaska Native patient navigators and the roles that they play within the systems that they are employed by. And there was a huge difference. I actually spoke with the primary investigator afterwards, and she told me that Mayo Clinic is far and above the one out of whatever, the one that's kind of doing the most. A lot of patient navigation services are only dealing with like insurance issues or scheduling, trying to get the patients the proper schedules, and then that's kind of where it's left at. So I think if we could develop a model, and really make that across the board, I think that would be huge.
You just kind of nailed it. I think um, it, part of the reasons that I have done all these many different jobs is because I start with one job and I burned out. Part of it is because once people knew me in the community that I was doing that work, they all came to me. And it just got to the time that I got overwhelmed. I think clinics and any community health service can help bilingual people um, grow up in their job by educating them more with whatever is the need. If you need to teach these people about breast cancer or cervical cancers or different kinds of things, um, in order for one person not to just do one person to do everything, but having several people doing the share work. Because yes, if you have one person and only one person in that clinic or that can provide that service for everybody, they're going to burn out. They are just definitely going to move on to something else because they are just overdoing it. And as much as you love your job and you want to provide that service for your community, it just gets to the point that I learned yoga, I did meditating, I did essential oils, I you name it, I have done it all. But it gets to the point that yes, you do end up burning out and you just have to move on. And I think that's something that a clinic or if they can keep providing uh, more help to those patients, to those people that are bilingual, and trying to get more people to work within the system. That will be good.
I'd also like to point out too, like with the Mayo Clinic team, we really are a team. and we help each other, we support each other. And then we'll also meet and talk about, some of our cases. And especially if they're difficult ones, we'll sit down with the rest of the team and say, just share where we're at. And then we'll get that input from the other team. And then the other part, of course, is just taking time off, making sure that's currently what I am. I'm actually on vacation this week, but came here just to speak to you all.
Well, that is very nice. I'm very happy you came because I always have to be here by myself.
We have time for one more question.
This is kind of a half-baked question, half comment. But the question about the metrics in terms of, measuring success of these navigator positions and these navigator roles, I think that if I were to be looking at metrics, I probably would be looking at metrics related to the system or the, clinic, to see if they have more than one person or two people for the entire Mayo Clinic. That's just amazing. But they have one, and there are a lot of clinics that and systems that don't. But there are so many different factors that why people are diagnosed or why they're diagnosed late, or death rates. That navigation is helping people through this system, and there are just too many other factors, I think, to consider, in terms of the mortality and morbidity. I think that this is such a critical role, but I do think that the change that needs to happen is, maybe not with the navigation as much as it is with the systems and the clinics, to make sure that they have people not just in these navigator roles, but in all of their different roles, their provider roles, that know community and know, cultures and, differences, and can be flexible in the way that they provide services and care to our communities, because our communities are, suffering from the fact that, we send people into this foreign, environment, and then we expect them to be able to sort of navigate their way through without that kind of assistance. And what you guys do is just invaluable, I think, to our communities and the clinics it is that we work for.
For me, it was, really growing up and going through the IHS system and going to my tribal clinic where I had one doctor, maybe one nurse, and that was it. And then you go to Mayo and it's like, what is all this? Who are all these people? So yeah, it's definitely powerful to have that understanding going into it. And then that way I can help pass that along, that knowledge along, and just help that patient feel even more comfortable. I did have a situation where one of my patients was actually meeting with the oncologist. And the oncologist was kind of laying out the options. Here's what you can have, and here's the options that you have. And he said that the patient just shut down, quit communicating with him, just stared at the floor and just listened to him. So he's like, well, maybe if I can get Skylar up here. As soon as I walked in the door and I introduced myself, and as soon as I told him on Stockbridge, Muncie, his face lit up, and him and I sat there and had a conversation for 10 minutes about our different tribes and how some of the people that he knew from my tribe. And then finally the oncologist had stepped in and say, hey, do you mind if I finish up here? Oh, yeah, doctor. Come on in, But yeah, it makes that difference.
Well, I think my point was, from diagnosis to detection to treatment, if the length has shortened because of navigators. And you're right, there are many other systems in place that play a role. But they did notice that with community health workers. So I was just curious about that. And I'm sure there are metrics out there that track that. But just wanted to know if that would be a good badge of honor for you all too. I think that's all we have today. Thank you all. And a couple minutes before the next session. Thank you, Skylar, and thank you, sir.
Thank you.